Hi, thanks for letting me report remotely. I'll be giving an MRI update, MRI technology update from the USC team, and this is Krishna Nayak narrating. I first want to mention that our work has been primarily geared towards developing new MRI methods and some novel experiments based on those methods that you could use to study pediatric sleep apnea, and also some potential tests for patient evaluation. A unique aspect of our work is that we actually reprogram the scanner. So the scanner is a programmable device that allows us to alter the way that images are acquired and reconstructed. And by digging deep into the software that runs these scanners, we're able to leverage some recent breakthroughs in what's called sparse signal and image processing that have allowed us to produce order of magnitude improvements in spatial resolution and temporal resolution. Our work is done on commercial scanners. We happen to use GE, and we have a collaborative agreement with them that allows us to do this, to program and augment the system. We also can share these softwares with sites that also use the same magnets, same vendor's magnet. So MRI has been used for OSA evaluation for quite a while. Static MRI of the upper airway has been around for decades, usually to identify anatomic locations of all the relevant soft tissues, and it's typical to acquire 3D scans with multiple different contrasts that each take about 2 to 4 minutes to acquire. So 2 to 4 minutes per scan and maybe 5 to 7 scans total. It's about a 30-minute exam. The images produced are gorgeous. They're very crisp, and you can delineate all the relevant soft tissues, but they're static. And so our work has been geared towards doing faster imaging and dynamic imaging. The protocol we've been using over the years involves preparing patients for the MRI and then doing a series of 2-dimensional real-time and 3-dimensional real-time scans while they're awake, and then repeating those scans over a longer period where we can get them comfortable and hopefully they'll fall asleep. We facilitate sleep by doing a prior mock scan to make sure they're comfortable and don't have claustrophobia issues. We also start the MRIs at 9 p.m. and ask the patients to go on caffeine restriction for a day. And we also built a memory foam bed. And one of our early aims was to actually change the MRI gradients so that they're quieter, but we actually found that was practically impossible, and we published a paper on that in our top journal. We do fast imaging by using custom coils, which we have procured. We also have custom pulse sequences, which are the way that the magnetic pulses are transmitted and received. And we implement our own reconstruction and post-processing. And in doing this, we're able to image the airway in real time with no sedation, no gating, and occasionally we create some artificial occlusions by applying an inspiratory load. Here's a picture of the setup. On the right is one of our subjects with a carotid 6-channel coil. This provides good signal in the area of interest. And on the left is a volunteer with the mask that has the pressure transducer and also has the airflow monitor and has bellows, and it just shows all the different instrumentation we have on the subject. Okay, so now I'll give just a summary of the year in review. At the start of the grant period, we were primarily focused on 2D real-time imaging. So we were collecting a handful of 2D slices during natural sleep. We have developed methods for obtaining 3-dimensional real-time data, as shown in this movie. What's shown is a mid-sagittal and a parasagittal slice, along with 22 axial slices that are just cuts from a 3-dimensional data set. We're able to get 1.5 millimeter isotropic resolution at about 2 frames per second. And we've had very good image quality in many of our subjects. In all of our subjects to date, only a couple have had poor image quality, and that was due to difficulties of positioning them in the magnet. Now here's an example from a patient. You can see that we're able to get this data and also synchronize it with other physiologic measurements such as mask pressure, airway volume, displacement in the abdomen, and heart rate. This actually is not new. We presented this to you guys last year in Irvine. What is new is that we completed development of annotation software. So now the doctors in Sally Ward's group are able to view these videos and annotate them. They're able to label events and analyze all these waveforms together using a MATLAB-based GUI. We've also developed some tools for segmentation because these three-dimensional dynamic data sets are enormous, and it is not practical to segment every single frame. So a student developed a simple region growing method to automatically segment the airway as a function of time. And what he did is he identified a region of interest that was behind the soft palate and the tongue, and then in initial frame placed a couple of seeds in the patent airway, and then used region growing to identify the volume of the patent airway. And for that frame, he used centroids of that segmented airway to identify seeds for the next temporal frame. And this is kind of a recursive procedure that was used to generate segmented volumes for an arbitrarily long video, and it basically reduced segmentation time to about 30 seconds for an entire data set, whereas it used to be several minutes per temporal frame. And here's an example of what we can get out of that. Initially, our patent airway looks a little bit like what's shown on the far left, and this technique could be used to identify occlusions when they happen, because during an occlusion, the two ends of the segmented volume do not connect. So if there's multiple distinct volumes, we consider that to be an occlusion. This we integrated into our interface, and now we're able to identify these such events. So on the left is a 14-year-old male with an obstructive apnea event, and the gray bars, the light blue bars are times of the so-called event as labeled by a MD, and on the bottom there's a little collapse indicator. The white indicates a collapse identified by the automatic segmentation method. And you can see that although the exact start and end times don't perfectly match, the presence of the event was identified, and we found this tool to identify all but one collapse in the data sets that we have analyzed. On the right, we have a similar example. This is also a different 14-year-old male with a central apnea event. The blue indicates the event identified by the MD again, and there was no collapse in these cases. So we believe this might be a way to streamline the processing of our 3D real-time movies. Another area we've done a lot of work on is improving our 2D compliance measurement. So we have been using this inspiratory load device that allows us to block the subject from inspiring, that creates greater airway motion during attempted inhalation. So basically a negative pressure is created, and then the airway area is reduced as a result. And we attempted to estimate PCRIT by doing a linear fit to the normalized airway area as a function of mask pressure. And some of our earlier 2D scans found that if we wanted to have enough points along this during this initial rapid change in airway area, we actually had to have very high temporal resolution on the order of 80 to 100 milliseconds. And so last year we presented to you single slice compliance data. Well, one of our big developments this year has been the incorporation of multi-slice acquisitions with no compromise in terms of frame rate. The way we do this is as follows. We excite multiple slices simultaneously, and if we just excited them simultaneously and acquired our images, what we would actually acquire is the superposition of the so-called k-space data from those three slices. When we reconstruct an image, you'd get interference. In fact, those three slices would basically be added to each other, and it would be difficult to interpret the results. However, if you apply a unique phase profile to each different slice and vary that phase profile for the different positions in k-space, what you can do is you can actually separate the three slices in a similar way that in cell phone systems, multiple calls are able to be differentiated even though they use the same bandwidth. So we multiply the acquired data by the conjugate of the phase profile and are able to separate the three slices. Now this does not come at any cost. However, there is a little bit of residual aliasing that increases the noise level in the images. So significant amounts of motion in one slice will lead to a slightly increased noise level in the other two slices, or the other n-1 slices. Now this cartoon is for 3 slices, but we've implemented this for 4 and now 8 slices. I'm going to show you some human data from 4 slices. So our goal has been to and completely cover the soft palate to epiglottis with a spatial resolution of 1 millimeter in plane, that's in the left, right, and anterior posterior directions, and get a temporal resolution of 10 frames per second or higher. And we used a synergistic combination of multiband excitation, a special sampling trajectory, multiple sensors, so multiple coils around the airway, and a technique called compressed sensing, which is the signal processing technique I alluded to at the beginning of the talk. Here's an example with 3 slices showing that you're actually able to measure motion in these 3 axial slices with 100 millisecond temporal resolution. These slices are each 6 millimeter thick with a 4 millimeter gap in between them, but those are parameters that we can easily modify. Here's an example in a subject where they're getting a compliance test, meaning that we're blocking their ability to inspire and watching change in airway cross-section. 4 slices simultaneously. And here's an analysis of that data, plotting normalized airway area as a function of time. So what you see on the left is a cartoon showing the 4 slices, starting out with an axial slice that goes through the tip of the soft palate, and then the 3 subsequent slices are placed at fixed intervals, basically 1 centimeter inferior of each of the previous slice. And if you notice, the normalized airway area is plotted as a function of time during this kind of constructed occlusion. This subject happens to be awake, a 15-year-old male with OSA. What you notice here is interesting. The site that is narrowest at baseline, which is the black slice, so slice number 4, is actually the one that's the least compliant. And here we're interpreting compliance as being the slope of this curve in subfigure B. Okay, so the slice 4 actually has the lowest cross-sectional area at 0 pressure, but that cross-sectional area varies minimally across the range of pressure, and it has the lowest peak rate. However, S2 and S4, actually in this case S1 and S2 have a higher cross-sectional area at rest or at 0 pressure, but have a much higher degree of compliance according to our notation, and they have a higher peak rate. So this was interesting to us because one of the previous uses of static MRI was to identify the area of greatest narrowing on a static MRI. This is actually the same idea has been used in cone beam CT in patients with sleep disorder breathing, and assumed that the location of greatest narrowing at rest was going to be the location of collapse. So we have at least one anecdotal piece of evidence in the contrary. Another anecdotal evidence, we haven't gotten great numbers here yet in terms of head-to-head comparisons, but in the healthy subjects we have scanned, there has been less variation in our measurement of compliance and peak rate across slices compared to patients with OSA. And here's just 2 examples. On the left is a subject with OSA, and on the right is a healthy volunteer. You can see the peak rate in the volunteer was always very close to -12, and the compliance also was within 10% of the values for the other slices, whereas there was significant variation in those 2 measures for the patient. Another area we're investigating is the use of CPAP during real-time MRI to visualize airway dynamics during sudden pressure change, and to measure the airway area versus compliance under various levels of pressure. Here's a picture of a volunteer wearing the same mask that we use, but connected to a CPAP device. The CPAP device, the tube was connected through the MRI scanner room's patch panel and then into the MRI scanner, so it's about 15 feet in length, and it was enough to maintain the pressure produced by the CPAP instrument. And we're able to make measurements like this. So here what's shown is, in the plot, is the red dashed line indicates when the CPAP is turned on or off. Ignore the value for that. But the blue curve represents the mask pressure measured by the pressure transducer. And you can see that when the CPAP is on, there's a increased pressure level, and there's some variations with breathing. And what's shown here in this video is just a short snippet just around the time when the CPAP machine is turned on. So you can see there the change in airway cross-section as it's being turned on. And here's another video as it's being turned off. So you can see the airway kind of close slowly as it's being turned off. And when the video loops, you might see a rapid transition in the opposite direction. Okay, so our plans for this is well, we noticed that we can capture aerodynamics during sudden pressure change, in this case instigated by CPAP. And our plan is to try to measure a peak rate during an MRI scan to observe the airway dynamics under different levels of positive pressure. Another plan I didn't talk about yet is that we want to incorporate tagging, spatial tagging, to better delineate regional compliance. So in that, I mean, we're going to apply spatial grid tagging. Spam tagging is the technique that it's given in the MR community, and then we're going to watch those tag lines deform as there's an airway change. Another topic we've done some work on is low field MRI. Using the funding from this grant, we started exploring whether the technology we've developed can be applied at lower field strengths, because all of our work has been on 3 Tesla high performance systems. We developed a simulation framework for predicting performance at low field, and we now believe that all of our methods that we've developed so far will work at 0.3 Tesla or above. And here I'm just showing our finding for the compliance testing. What's shown on the bottom right is a picture of DICE coefficients, which is a measure of the accuracy of airway cross-section segmentation as a function of simulated field strength. And as you can see, down to about 0.3 Tesla, the agreement is quite good. And we found similar performance can be had for other tests that we've been working on. So this actually has pretty significant implications, because lower field strengths will obviously be more comfortable because there's less safety issues and less physical constraints on the device. There's also less interaction with devices, so there's a potential for, at low fields, imaging. There's a greater potential at low fields to imaging people that have appliances or maybe even these stimulators installed. And it could open up some interesting doors for MRI testing in patients with this condition. Here's a list of our publications to date, and I'm happy to answer any questions. Thank you.